Here we go.
All right.
Good
Well,
evening, everybody. Thank you for joining our Men's Health webinar. I'm Preston Brickner. I'll be your host and moderator for the question and answer portion. Starting a couple just quick housekeeping items, and then I'll turn it over to our speaker. First, the attendance tonight is completely anonymous to all other attendees. No one will see your face nor your name. Any comments or questions you have for us can only be seen by myself and Dr. Natale. If you wish to ask a question, just type it in your chat box. It should be at the lower part of your screen. Tap right there, and we'll get to as many of them as we can at the end of tonight's session. That is Dr. Natale's favorite part. So make sure if you have a question, please do not hesitate. Our whole presentation tonight with the question and answer should last approximately 1 hour. This one's a little shorter, so probably less. Tonight's presentation will be presented by Dr. Richard Natale. Dr. Natale was born and raised in Southern California. As the son and nephew of physicians, he knew from a very young age that he too would pursue a career in medicine. He attended the University of Southern California, where he graduated with honors with a bachelor's degree in biological sciences. Given the opportunity to attend his father's alma mater, he went to medical school at the University of Louisville School of Medicine in Kentucky. Dr. Natale completed his urology residency training at the University of Florida and chose to practice medicine in North Carolina for its natural beauty, friendly people, and unique medical community. Although Dr. Natale's expertise covers a broad range of urological conditions, he has a special interest in men's health. This area of urology includes treatment of conditions such as erectile dysfunction, Peyronie's disease, low testosterone, enlarged prostate, or BPH, and tonight's topic, stress urinary incontinence. Dr. Natale, I know you're a busy guy. Thanks for joining us this evening. Why don't you take it away, sir?
All right. Well, thank you, Preston, for the intro, and thank you for everybody for attending. You're right. I can have some long days at work and all the rest, but I will tell you that the opportunity to do this really excites me. It's something that I actually look forward to, because if I could spend more time working with my patients and educating my patients on things, and we work together to find solutions, man, that what a great world that would be. And sometimes what we need to do is just set aside times like this where I can have a full hour to go over topics that I can't do in the office because we see so many patients. So I do appreciate these opportunities. We actually had a great talk not too long ago about erectile dysfunction, and this was going to be part of it as well, part of almost a survivorship discussion related to prostate cancer health and and all the rest. But we ran out of time. We just had so many questions and just great feedback and interactions. So, certainly encourage that if we can tonight. Love questions. We'll get through these slides. There's going to be some housekeeping stuff we need to do throughout, and certainly having this as a backdrop, but trying to go through it with a little bit of haste so we can get to the questions will be a good thing. So we kind of start off the whole discussion about this, about information that you can look at, more unbiased, educational information, to reference perhaps questions you may have that we don't get to, or, look at pictures and things that can kind of explain these procedures a little bit more in depth that we're about to talk about. So certainly if you can, like you to scan that QR code on your phone. You can go to that website later. You have more information about how to address the issue at hand, which is today we're talking about leakage. The information you heard about me, the only thing I will add to the whole discussion is if you ever want to get drilled down on some more information, either about me or some of the issues that I address and treat as a urologist, even some educational videos, I direct you to my website. It's a personal website that I put together and have kind of maintained over the years for the exact purpose of education and outreach to patients. So look at that web address. Remember, charlottemenshealth.com. And in the meantime, let's get started on our topic of this evening. So wanted to go through this concept of male leakage. And we're going to set this aside from other types of leakage issues, particularly when we think about men-women dynamic. A lot of times you hear women will talk about having babies and coughing, laughing, sneezing, and losing their urine. And so when you look at that, there's somewhat of a natural consequence of age, of the natural consequences of having children. But when you're looking at it and applying the same to men, it's a bit different, right? So we don't have the same, we have similar anatomy, but not the same. And so when we develop urinary incontinence issues related to lack of muscular support to hold our urine, it's typically related to some sort of procedure or treatment that we've had previously, most often for prostate cancer. If you looked, a lot of the new cases that we see or the people worldwide were probably tied into a lot of the medical issues that dealing with what I just said. So either prostate surgery because they've had urinary issues like enlargement and blockage symptoms that perhaps something went awry, or more commonly, treatments of prostate cancer, including surgical or radiation treatments. Now, what I like to kind of joke with folks is that the prostate and bladder were not really very elegant organs. They just have a couple of jobs. The prostate itself really only has one job, and that's to give us allow our semen to be a bit more liquid to be able to impregnate a woman. The bladder, all it really does is fills up with urine and says, I gotta go, and then squeezes. It's the only things that it does. Well, understanding the way all of that works is going to be important because it's going to talk about how we go to fix the problem when we do develop these leakage issues. So for example, one of the things I like to tell folks is that we aren't in control of the actual urinary process. We're in control of relaxing our pelvic floor muscles. So when you get that urge to pee, your bladder is telling you to go to the bathroom, but rather than your bladder being told by your brain to squeeze directly, what happens is you relax your pelvic floor. The muscles we call the sphincter muscles that are around the base of the urethra and prostate, kind of like on an image that you see to the right on the screen. That area relaxes, allowing the urine to pass through. The bladder does all the rest of the work for us. Now, as I just made mention, the primary causes, as you see here of this, are typically related to treatments regarding prostate enlargement, prostate cancer, or perhaps some other issues that are a little bit more nuanced in particular for some folks. For example, people who have had surgery for scar tissue in the urethra may potentially develop issues with leakage and may need that treated with a sphincter device. Nevertheless, those are kind of the causes there. I'd say by and large, when I'm dealing with folks with stress incontinence, it's mostly going to be related to prostate cancer. Now, goes without saying that leakage for anyone, men or women, is a tough thing to put up with. Certainly, when I counsel women about leakage, they'll sometimes say, well, I heard it's just part of being older. And okay, well, maybe some of that's true. None of us at all, men or women, want to sit in pads or diapers. Certainly not what we're used to. And we figured we left that behind a long time ago. So we can see that the impact of having these issues really isn't just the actual leakage and maybe even the cost of supplies and all the rest, but it starts off very simply with the internal parts of things, the way you feel about yourself. And it absolutely, particularly when you're talking about leakage following prostate cancer treatments and all the rest, you've already gotten through a disease state that scared you, right? You had to go through a therapy, they have surgery, all the rest. Now we're dealing with some of the after effects, which can be very trying for patients. Well, when we look at the more specific now relationship about treatments for prostate cancer and stress urinary incontinence, you see this. We start off with these statistics, and if you look, there's a lot of prostate removals that are being done. Okay, so on the left-hand side of the screen, if we're estimating, less than 100,000 prostates are removed per year, that's an enormous number of people having this treatment. If you look to the other side of the screen, the percentages of leakage that occur actually are kind of all over the map. As a matter of fact, I would argue, while the statistic is well founded, obviously there's been research that isn't done. I would argue that if you loosen the definition of stress incontinence following surgery even more broadly to include just accidents here and there, or something what we call coital incontinence, where you leak during sex, you actually broaden out that definition. My suspicion is that number is actually an underestimation. Now, Why does this all happen related to the prostate? I mean, I keep saying all this, and I really haven't shown you more specific anatomy. And there's going to be a very, very key point that I can make here, which is the following. On the furthest to the left of the screen, you see that there's the prostate, that where the prostate actually lives, the base of the bladder. When the prostate's removed, it's not unpeeled off of the urethra. In fact, we kind of transect, or we cut through the top part as the prostate meets the bladder, and then the bottom part where the prostate itself has the urethra coming out of it. So we remove that entire segment, and then we usually pull the urethra towards the bladder to sew everything together. Now, the surgery obviously works to help with prostate cancer cure and treatment. But while they're doing that surgery, they're starting to impact and damage the nerves, unfortunately. And no matter what has been done, we know that there's still some impact on urinary control. So, a brief aside, there was a study some years ago through a European surgeon who published in the European journals his experience, where he was looking at, for example, and this is related, prostate patients who'd had cancer, and he removed the prostates. And he was just simply asking about their issues with erectile dysfunction. And he said, before surgery, did they ever answer a perfect score on their questionnaires? And did they do it afterwards as well? Only 5% of the men that he operated on, which is a high volume academic surgeon at a referral center, only 5% of patients reported having no problems with erections. Now, why am I bringing up erections when I talk about leakage? Because the whole point is that we've now moved into a generation or era where we're using robotic surgery, much closer attention to the detail of the anatomy of the prostate, more importantly, the anatomy of the nerves around the prostate. Many efforts are made to spare, as they say, or preserve the nerves. Well, with the concept of protecting erections, but it also, those same nerves are partially involved in the control of our urinary flow as well. So what can happen is, no matter how well the procedure, no matter how good the procedure is going through, no matter how experienced the surgeon, the very fact that they're interfering in that anatomy and pushing the nerves aside and trying to remove the prostate sets you up for these problems, both the erection issues and leakage problems. So certainly I don't ever want to call it a complication of an operation, because the reality is, even in the best of hands, these are still things that you're dealing with. So I almost look at this as a side effect instead. And if we have a side effect of treatment, if we have a leakage issue, let's say, well, then how do we fix it, right? So that's the next kind of the next steps here in our conversation. Now, very often in patients' treatments, as we talk about, if you look, I'm almost going to kind of reverse the order. Looking at the right side, I think a lot of people just cope, right? We just talked about women who will tell me it's part of aging and all the rest. There are plenty of men who live in pads. There's men who live in diapers. Some men wear things called condom catheters, or they use penile clamps. And certainly, we have to work on those things, right? We have to be okay with the issues that have developed and figure ways how to solve them and just generally cope with it. But certainly ignoring the problem and only using catheters or pads and all the rest, well, I think there's other solutions for that, right? So then we start talking about the more commonly employed things that most doctors are going to talk to you about, or at least they should, which is physical exercise. So these pelvic floor stretches and muscular contractions like Kegel exercises, or watching what you eat, what you drink, making sure to go to the bathroom on a scheduled basis so you don't fill up a lot with urine, so on and so forth. Those are the simple ways we can do, simple techniques we can use to start improving our control. But the reality is that ultimately, even when you do all of those things, there's still going to be a portion of patients who are just simply unable to treat with these methods. And now we need to step it up to a more invasive treatment. And the fact of the matter is that oftentimes when we hear surgery or invasiveness, or cutting and all this other things, there are people who will say, no, let me just go back to coping with it. But the reality is that there are therapies that are straightforward, that are definitive, that are minimally invasive, certainly a lot easier to cope with and get through than what the surgery that got you there to begin with. So, for example, there's the advanced male sling, which I want to spend a bit of time on, of course, because I do think this is a great treatment option, particularly for men who have the more mild to moderate issues. Now, what I mean by that, there's certain criteria about that we can use scientifically to kind of break down what would qualify as mild to moderate symptoms. But the way I see it is this: if you're able to control your stream midstream, you have some muscular contraction, that you can kind of slow things down. If you have had improving but not completely resolving symptoms of leakage, if you're using a pad, maybe 2 a day, 3 perhaps, and you're not soaking in diapers, you're a great sling candidate. There are some other exceptions we'll talk about in a minute, but for the most part, these are the guys that I'm dealing with mostly with prostate cancer who've had therapy, right? Not everybody's going to be coming into the office in diapers and leaking like a sieve, but they will, a large number, have some degree of leakage that we're describing. And so those are the kind of ideal patients for male sling. Now, why do I like this idea and want to spend this time here is because it's an elegant way with how it works. And more importantly than that is 2 things. One is that there's no mechanical parts. So there is no failure that we have to worry about from a mechanical part that there's going to wear out or so on and so forth. So I don't worry about that too much. But the other point I want to make is this, is that when we see how this works, we understand the science behind it, you'll understand that a relatively minimally invasive procedure can be done to almost immediately impact your leakage issues. The way it works, and won't get into tremendous detail in terms of the science that back this up, but over the years, we started to recognize that it's not just an issue related to the nerves being damaged during the surgery, but there also may be a degree of what we call pelvic floor relaxation. So much like what can happen to a woman who's had babies, the pelvic musculature is weaker and relaxes some, the urethra changes its position. And as a result, may encourage some degree of leaking. All that this sling is literally a way to reposition. So I kind of like put my hands up like this because what it does is it acts like a hammock and it supports that urethra channel. So that way you have good support and control, get you back to being as dry as we can get you with this device. Now, again, we'll put a little asterisk about it. There are some patients that are not great candidates for it. We'll talk about momentarily. But by and large, patients who can have this procedure, it's because they have mild to moderate leakage. It's 1 incision in the groin area, or underneath the testicles, I should say, and 2 very small stab incisions in the groin to allow us to pass the sling and get you under control. Now, this is opposed to the more gold standard treatment, which we'll talk about, because here's my break point and segue, which I kind of been alluding to. With the sling, I'm going to defer to that as my primary treatment for a good number of my patients. The exceptions, severe leakage. So people who are in a tremendous amount of pads and they're pouring into diapers and they're miserable. I will not be able to get you as dry as I could with what's called the artificial urinary sphincter. Or if you've ever had any sort of radiation to the pelvic floor, for example, men who've had prostate removals, occasionally they need to have radiation to kind of clean up what's left over. In those folks, radiation in that area does not allow me to reposition the urethra tube where I need it to be. So what winds up happening is patients will fail and they'll be leaking on themselves again. So I say all that because if I bias towards that for milder cases, then I start moving into this whole discussion of, okay, so what if it's worse, or they've had radiation, or they just want to make sure they're as close to 100% dry as humanly possible. This is the next step. This artificial urinary sphincter device has been around for now 50 years. Elegant system. It involves 3 parts, which we'll see about in a moment. But basically, there's a cuff or a part that wraps around the urine channel that stays closed all the time. There's a scrotal pump that's placed right underneath the skin of the sac. And that's the pump that you actually squeeze when it's time to go to the bathroom. That pump opens up the cuff that's around the urethra channel and you pee. So excellent device, been used for years and is a long track record and is something that in the right patients is a great option for therapy. Now here's the picture we're just talking about. I didn't tell you about the PRB. That's the last part of it, the pressure regulating balloon. But the two pump parts are the most important, which is the control pump itself in the sac, and then that cuff that goes around the urethra channel. Now, I got to say this because I get kind of dorky about all this, but I love it. The way the pressure regulating balloon works, there's a certain surface tension that's on that. And when the cuff, when you press the button, it shifts the fluid out of the cuff into that pressure regulating balloon temporarily. That balloon wants to restore itself to its normal state. So it will start squeezing back down to the regular size over a course of time, usually 45 seconds or longer, in order to close that cuff up again. And this system, it's not going to make you pee. You don't get a special signal for it or all the rest. You need to go pee. You go to the bathroom, you squeeze the pump once, opens up, you flow, and you're able to go to the bathroom. Now, I love this device, but let's look at, the picture about this device, but let's look at a video as well so we can kind of take a peek and see. So it gives us, we always have a little bit of a lag in the beginning with this video, but as you see here, we're now getting the picture that we just saw a second ago is the illustration. Will kind of point out to you what I was just saying to you verbally, which is you press that button once and it opens things up. Now, patients have asked, well, what if it closes down and I need to pee again? That's okay. You just squeeze it again one time. That allows the pump to open. So certainly no reason why you cannot, go more than one time with all that. I'm going to try to scooch through that video so we can keep going. So with the difference between this surgery that we're doing and the others. Okay, so both of these are outpatient surgeries. You're going to go home the same day. Both of them for me take typically anywhere on a low end 30 to 40 minutes, on a higher end perhaps an hour to an hour and a half, but they're still pretty short procedures done under general anesthesia. With the sling, there's the incision underneath the testicles, as we talked about, that area between the testicles and the rectal area. And then the two small stab incisions we place in the groin, kind of in between the thigh and the groin. With the sphincter device, generally there's going to be two incisions. The first will be the incision underneath the testicles, very similar to the sling. The second will be an incision above on the belly, closer to where we put the cuff in, the pump in, as well as that little balloon that they showed in the diagram. So typically two small incisions. They're not large scars. We don't need to make major openings, just enough to be able to see what we need to see and get the job done. What's nice about this is that typically I won't really put you on the same strict downtime protocols. There are some exceptions with, for example, a sling where I get a little bit cautious with, but generally speaking, the first few days to weeks, just take it easy. Ice packs for discomfort, things like this, that issue will resolve. And then with the sling, you'll have immediate control. With the sphincter, we got to wait so I can turn the device on, unfortunately, but we do wait for about 4 to 6 weeks so you can fully heal before we switch things on to get you dry. Nevertheless, when you look at the success rates by just now using the sphincter, but generally speaking, you look at these numbers and, low ends of 85%, but high ends of 90 to 95% of success, right? Why? Because I know I can get the device in, I know we can size it appropriately and get it working well, but it's really the after effect, what the patients feel. And being able to get you dry and being able to get you back that control, that's kind of the reason why we show you these numbers, because more than 90% of patients are doing just that. And of course, that means that they're willing to go out and say, hey, guess what? My brother, my friend, whoever it is, you need to get this fixed with the sphincter. Anyhow, when you look both devices, what I mean by device, again, the sling versus the sphincter, people also ask the question, what about coverage and cost and all the rest? I have, knock on wood, I've not seen any issues related to coverage with these particular treatments, because this is treating a leakage issue. While we may have issues occasionally with penile implants, it's certainly not the case that I've ever experienced with urinary treatments. So typically these things are covered. We would make sure about that before there's any sort of point of no return, so to speak. Now, obviously, if you use an example of a patient like Herschel here, who I've actually met the guy, he's a great guy and patient advocate, educator. If you hear from folks like him, like Herschel, you realize that they had lost a part of their life, right? And I mean it, that the quality of their life was impacted, and we gave certain things back to them. And I'll tell you, as a doctor, we all want to help our patients, and there are a few joys in our jobs that we really really look forward to, because obviously for us, just as much trying to help folks, we're also dealing with their stress and their pain and their sadness and the diseases that they're dealing with. But I can tell you, the one thing that always it really astounds me is a story I'll share, which is there was a patient I had years ago who was told by his outside urologist there was no treatment for his leakage after his prostate removal. Once I put his implant in, his sphincter device, and turned it on, I'll never forget that appointment. I watched a grown man in his 60s crying, sobbing, and he hugged me. He just gave me a big bear hug, because he went from living in diapers and pads for, get this, for almost 15 years after his surgery to being dry. It was just an incredible thing. So certainly, I can't speak enough about why I think this is a good treatment, these treatments, why I encourage patients to talk about it, why I really pursue this therapy, is because it really does give you back a piece of your life that you had to sacrifice, unfortunately, with this, with as a result of your prostate cancer, let's say. Now, everything comes with its downsides. Of course, there's always risks to things, and we would be more specific in our discussions if you are a candidate for one or the other. What I like to tell everybody is this: when you look at device failure with slings, it's about patient selection. We talked about radiation therapy. We talked about, what we do to reposition and things like that. And there's things that we can work together on to limit the likelihood of device failure. With that being said, sometimes it's not enough for treatments. That's okay. But it doesn't burn any bridges for example, having to do a sphincter device if necessary. So I say all that because yes, it can happen, but the rates are very low in my experience. And it's all about how we work together, our expectations, and what we come up with in terms of solutions for whatever we deem as a failure. That's the one risk. If you look at the rest, I would tell you on that list for the sling, it's not common, although it's possible to go into urinary retention temporarily. Now, some people do require more intervention, but most often that will resolve with time. Same thing with issues related to the postoperative discomfort and pain. We can see those issues, but it's typically a short-lived and easily treatable issue. Same issues here on the flip side with the urinary sphincter. The only exception being that because it is an implant with a bit more complicated parts, eventually the device will quote unquote fail. So I say that because the more you use a very small, very delicate device that's put together, eventually there's going to be some issue that will not have it work as well as it should, and it needs to be removed and replaced. That happens, I will tell you, in 15 years of urology. The oldest person I put in a sphincter was 93, and he was cleared by his doctor. He'd had 2 other sphincters over the 25 years that he had dealt with his prostate cancer, and it just stopped working. And he said, I don't want to leak. And as long he was healthy enough to go through the surgery, he did just fine. So I say all that because yes, there are some risks, but the benefits far, far, far outweigh the risks. Well, that's kind of my speech, and I probably elaborated on certain areas a bit more because I had a bit more time to be able to go through these slides. But if there was areas that didn't make sense to you, certainly we have the time now to ask questions. If you do want to go back and look at those resources we talked about, particularly with the fixincontinence.com, please do. This is great reading material for you to reference. That being said, we have some more of the housekeeping things. That being said, I personally like to open these things up to questions. Now, it can be questions to me. Another opportunity is we just made mention about Herschel, for example. There are patient advocates that if you want to hear from someone else other than this guy, more than happy to direct you to them as well. Sometimes it's nice to hear, an actual consumer of the product tell you what they think. So with that being said, because we're kind of at that point of
Yeah.
the talk, we have time
If
for
you could go,
questions.
if
I'm
you
gonna
could go all the way down to the last slide, Dr. Natale, real quick for us. Just keep going, just so we can get through our references.
There we go. Got it. Yeah. All right. So we got our references that are there, and of course